There is something genuinely strange about this moment in psychiatry, and it's worth sitting with that strangeness before analyzing the trajectory. Substances that were classified as Schedule 1 in the 1970s, meaning no accepted medical use and high abuse potential, are now producing clinical trial data that outperforms the best tools mainstream psychiatry currently has. The dissonance between that regulatory history and this emerging evidence is significant, and it deserves acknowledgement. The MDMA-assisted PTSD therapy data is the strongest case. Phase 3 trials showed that 67% of participants no longer met diagnostic criteria for PTSD after treatment, compared to approximately 30 to 40% remission rates for conventional pharmacotherapy. That is not a marginal improvement. That is a different category of outcome. For a condition like treatment-resistant PTSD, which affects combat veterans, trauma survivors, and first responders at rates that existing treatments demonstrably cannot address, a 67% remission rate is, clinically speaking, extraordinary. Psilocybin trials for treatment-resistant depression have produced similarly compelling numbers. So the pharmacological case is actually relatively settled at this point. The remaining challenges are structural, economic, and deeply political. Psychedelic-assisted therapy is not a pill you take twice a day. It is a protocol that requires trained therapists, controlled and comfortable clinical environments, preparatory sessions, the guided experience itself, which typically lasts 6 to 8 hours, and integration sessions afterward. This is fundamentally incompatible with the 15-minute medication review that most psychiatric care has collapsed into under reimbursement pressure. Healthcare systems built around efficiency metrics are not naturally equipped to accommodate this model. The insurance question is also worth naming directly. Insurers will not cover psychedelic-assisted therapy until economic modeling proves it is cheaper than the alternative. The alternative, in many cases, is a patient on psychiatric medication for 20 or 30 years, which, across a lifetime, is genuinely expensive. If a few psychedelic therapy sessions produce lasting remission, the economic model may actually favor the new approach over time. But over time is not how insurance coverage decisions are made quarterly. There is also a regulatory turbulence that deserves a warning. The FDA's 2024 decision to reject MDMA-assisted therapy for PTSD, citing methodological concerns about trial blinding and therapist conduct, was a reminder that this pathway is not as smooth as the clinical data might suggest. Regulatory approval requires not just efficacious data, but methodologically unimpeachable trials in a context where blinding is genuinely difficult. You cannot give someone MDMA without them knowing they received it. The 15-year timeline for full integration is probably realistic, if cautiously optimistic. What's more certain is that the scientific legitimacy of these approaches has already passed the point of reversibility. The question is no longer whether, but when and under what conditions. Getting those conditions right, training standards, clinical protocols, equitable access, will determine whether this becomes one of medicine's great advances or another expensive treatment available only to those who can afford cash-pay clinics.